Brilliant. So, good morning, everyone. Welcome to our South Yorkshire Bitesize series. I'm Natalie Wong. I am Programme Manager for the South Yorkshire Innovation Hub at Health Innovation Yorkshire and Humber. Today's session will be taking a health inequalities approach to cholesterol management in secondary prevention on CVD. And we'll be joined by the lovely Ebun and Daniel Fitzgerald from South Yorkshire ICB. These are all part of a massive set of webinar series, which essentially highlights research and innovation best practice all across our South Yorkshire region, and it will run weekly from now all the way up until January of next year, with each month focusing on different themes. So, for example, this month we're on prevention, next month will be workforce, and the one after will be economic participation. Now, in line with the 10-year health plan, we want to maintain the energy around innovation because this is a priority for all of us. It drives progress, it enhances problem solving, but it also fosters growth. We hope today you'll feel inspired by our lovely speakers. Hope you can gain some insight around research and innovation and hopefully take away some of those back to your own organisations as well. So now I will pass you on to Ebun and Daniel for their presentation. Thank you.
Thank you, Natalie. So Ebun's going to bring up the slides. It's lovely to come and present to you today. So I'm Daniel Fitzgerald. I'm a prevention programme manager working across South Yorkshire ICB, and I lead on this the CVD prevention programme. And Ebun is with me, who led on the project with myself as well. Ebun, do you want to introduce yourself?
Thank you, Daniel. My name is Ebun Ojo. I am a pharmacist by background, and at the time of this project, I was sort of clinical lead for this project, but I'm senior pharmacist within the MedSoc team leading on cardiovascular disease for South Yorkshire ICB. And so hopefully you will find what we did interesting. I dare to hope you might find it inspiring, but I'll hand over to Daniel to start us off. Thank you.
Thank you. Yeah, so I wanted to give a background really first around why we were focusing on cardiovascular disease in the first instance. So the first diagram kind of shows you the gap in life expectancy between our most and least deprived populations in South Yorkshire. So CVD being the largest cause in that gap in premature mortality, but it is preventable through healthy lifestyles and detection and management of our CVD risk factors. So there's a huge opportunity there. South Yorkshire also has a higher incidence of CVD compared to England average, and it has the third worst mortality from circulatory disease in the country. So there's a massive amount of work that we need to do to improve our population's health on that. Then looking at this diagram, this shows the fact that people living in the most deprived decile are twice as likely to die early from circulatory disease than those in the least deprived deciles. So there's a massive health inequalities difference here. So there was an opportunity nationally for funding to help local health systems deploy innovative ideas and solutions to implement in the new NICE lipid management pathways. So the funding intended to implement those pathways successfully, remove barriers to implementing the pathways, allow innovative approaches, and support practical obstacles to deploy the work through education, promotion, and transformation work. So we looked more at how we could focus on lipid management and where those opportunities would best be, and we really noticed a treatment gap. So this is where there was a wide gap in the proportion of patients treated to target across our 4 places. So these diagrams show each column is a different place in South Yorkshire. And we also looked at the kind of poor use of high intensity statins for people with recorded CVD. So actually there's a massive opportunity to make sure that people are on the most optimal treatment. And actually, I think it's really surprising the fact that there's only 34% of patients in South Yorkshire with high cholesterol are treated to recommended national targets. So, there's a huge amount of people receiving suboptimal treatment there. So we looked at how this related to health inequalities, and you can see there the clear kind of difference between the most and least deprived. So there's a higher number of patients who have a cholesterol above the recommended targets, i.e. worse than the national targets, than those living in the least deprived areas. We also looked at how this kind of varies between practice. So you can see there that as the IMD score increases, so does the number of people with a cholesterol out of range. And then we also noticed that actually this is worsening over time. So you can see there from June 2022 that the slope index of inequalities, that's a measure of our health inequalities, has gotten worse over that time period. So South Yorkshire being the dark blue line there, and the other places in northeastern Yorkshire being the other lines, and the dotted line being England average. So that was kind of worsening. So what we did was we brought partners together across South Yorkshire, including our public health colleagues from across the councils, Meds Optimisation, the Health Innovation Network, and other colleagues within the ICB, to look at how do we develop some fundamental pillars for a programme that we could implement through the funding opportunity that was available. And where we came to was kind of those 4 pillars. So the first being around increasing the confidence and competence of primary care professionals to optimise lipid management through primary care education. The second being, how do we incentivise primary care to treat more people to the nationally recommended targets? Then how do we increase patient education and public awareness of cholesterol management and the importance of managing and being treated to target? And lastly, around improving equity of access to our secondary care services. So I'll pass over to Ebun now to talk through how we went about implementing those fundamental pillars.
Thank you, Daniel. Right, so in terms of the first approach, which was increasing the confidence and competence of primary care professionals around lipid optimization, we actually did this as a joint effort with the Health Innovation Network, which was also at the time sort of embarking on a program of cholesterol education for the wider region through the Collaborative Lipid Fund. So what we did was we ran some local sessions, but actually we also did some joint sessions that were open to clinicians across the entire northeastern Yorkshire footprint. Clinicians were encouraged to use the AHSN, well, AHSN at the time it was called, but what the Summary Lipid Optimization Guidance for Secondary Prevention. So it's basically an abbreviated version of the national guidelines specifically for secondary prevention. All of our education was recorded. People who attended got certificates of attendance as well. And actually, we were able to house all of those recordings and resources on a SharePoint page that people were then able to access at different points. And actually, it then goes on to link in with the next pillar, which was around a targeted incentivization scheme for primary care to treat more patients to the nationally recommended targets. So while we were looking at how we were going to implement an incentivization scheme, we had multiple vehicles. So we had vehicles that were already there. So local incentive schemes that were already in motion that we could employ or implement. But however, it would have meant sort of implementing the incentivization scheme across the entire group of practices within South Yorkshire. However, we knew that what we wanted to do was drive down health inequalities, and actually just by incentivizing everybody to do the same work, we would just be perpetuating the same level of inequality. And as Daniel said before, we found that there was a link between where patients were registered and their likelihood of being treated to target. So what also we didn't want to do was an incentive scheme that was practice-based, because if a practice didn't have the knowledge and the competence that, to be able to do the work, then just incentivizing them doesn't necessarily provide them with that. What we wanted to do was an incentive scheme. What we came up with, rather, was an incentive scheme at PCN level that actually allowed PCNs where some of that expertise already existed to be able to share that and make that available to other patients that might not be registered to their particular practice. So we invited 18 PCNs across South Yorkshire to participate in the incentive scheme. All but one agreed to participate in the incentive scheme. And what that actually also meant was we were actually able to put together a very what's the word I'm looking for, attractive incentive scheme, because it was to a smaller number of PCNs given our finite funding wallet. The scheme was initially supposed to run from September to March, but then we were able to extend it to the next September, so it actually ran for a full 12 months, and we will come to come later to some of the results in terms of what we saw as a result. Many of the practices that were involved, but particularly in our Doncaster region, if you remember from the bar plot that Daniel showed, Doncaster was the area with the lowest level of lowest number or proportion of patients treated to target. So obviously, doing a targeted incentive scheme meant that we were able to provide more resources for the place where, in the place where it was most needed. We also didn't want to situate, one of the things that sometimes we struggle with is sort of incentivizing twice to do something. And at the time when we'd been putting this program together, just as we were about to just as we'd gotten the funding, we the QOF indicators had been released. So we knew that cholesterol treated to target was going to be in QOF. But the reason this was particularly an advantage for us is because with QOF you've got your minimum threshold. There were quite a few practices within that South Yorkshire who weren't even meeting the minimum threshold, and obviously would have to do a lot of work just to get to the minimum threshold, but wouldn't get any support, remuneration, to be able to do that work. So this provided a really good opportunity to allow those practices to actually be engaged with cholesterol, treating cholesterol to target, because we weren't using the same parameters in terms of achievement as QOF. They were incentivized to treat to target per patient as opposed to having to treat to a minimum level. So as I said, we educated our healthcare professionals. We had a targeted incentive program, but we actually also went out into the community. Again, this was also in partnership with the Health Innovation Network. We went out into, we did some work with Doncaster, for example. We did some work in Barnsley. We did some work in Sheffield. So we went to different communities where we were able to do point of care testing of cholesterol. We were able to engage directly with individuals, provide cholesterol awareness and education, and talk to people about their cholesterol and why it was important, especially those who came and spoke to us and said that they had a history of cardiovascular disease, the importance of treating their non-HDL cholesterol to nationally recommended targets. And then the final pillar, which was also very, very important to us, was to improve equity of access to our specialist lipid clinic services across the region. We had a situation where of our 4 places, only 3 actually had a lipid clinic service. The 4th place didn't have a lipid clinic service. We had been successful, thankfully, through a different program to secure some funding to actually put in place a pharmacist-led specialist lipid clinic service in the 4th place. But that was still very much in its infancy. But even amongst the places that did have a lipid clinic service, there was a wide variation in terms of the referral process capacity and waiting times, particularly the waiting times. So you had people in some places only having to wait 8 weeks for a referral, to be seen by a lipid specialist. And in some other places, they were waiting as much as 18 months to be seen. So it was important for us to achieve parity of access across our places so that patients actually were able to get specialist lipid clinic advice and be started on some of the newer injectables like the PCSK9 inhibitors, which can only be given in hospital. And so we provided targeted funding again to reduce lipid clinic waiting times. So the funding was for them to expand the capacity within their clinic to drive down those waiting times and hopefully to improve access to medicines for the patients in our population. So, you know, it was very ambitious, it felt very lofty, but at the same time, it felt that it was the right thing to do. And as a result of all of that work, as I said, we did create a landing page, and the landing page actually is still functional. We're able to, you know, continue to use it as a way of educating our clinicians around cholesterol and around treating to target. So this was the initial landing page that we created, but actually that's now evolved into a South Yorkshire wide landing page that covers, you know, all aspects of prevention, including primary prevention, so weight loss, quitting smoking and the likes. And so when we finished the incentive scheme program, throughout the program, we were collecting data, and we saw data that actually showed, for example, how we were increasing the use of every single class of lipid lowering treatment. But the main important thing for us here, and the reason why we took this targeted approach, was to increase the proportion of our patients treated to target. And actually what we found was that we had, by the time we were finishing the program, we had treated over 6,000 more patients to nationally recommended cholesterol targets over the course of the project. But more importantly, almost half of them were from our core 20. So for us, that actually represented a success because, and I'll show you, shortly actually what that looks like. A reduction in that gap, in our inequalities gap, the fact that we were able to treat a lot more of our core 20 population to target, because we knew that they were the ones less likely to be treated to target from the outset. So looking at the slope index of inequalities again that Daniel showed earlier, if you remember, previously South Yorkshire had a curve that showed that the gap was increasing, and actually we were the worst of all of the other 4 places within northeastern Yorkshire. But as you can see, by the time we'd started, and by the time, you know, by March 24, which is when we had the data until, as you can see, we actually started to get a massive downturn in our slope index of inequalities. And what's been so remarkable to see is that not only has this so at the time of doing this work, as you can see, March 24, it was in a downturn, but it was still over 4%. But actually, as of the most recent data, we are doing even much better, and actually we're now under 4% in terms of our slope index of inequality. So this is the most recent CVD prevention data for our region. Now, it wasn't easy. It wasn't all, it wasn't all, we want to do this, let's go ahead and do it, and and everything was perfect. There were challenges for us. We had challenges with the workforce. At the time, we had, obviously, with the workforce, that's always been a challenge for primary care. Having enough people to do work, especially when it's additional work. We talked about the competence and confidence, and that's the reason we had that other sort of pillar that we felt was absolutely important to tackle, as well as conflicting priorities. There were other aspects and other targets that primary care obviously needed to meet in terms of same-day access. But at the time also, there were issues around the collective GP action, which was very much well underway at the time. And there was also, at the time, that was when we had a lot of the strikes in secondary care. So that also did cause challenges for us in terms of engaging with our secondary care colleagues. We also had challenges in terms of the differences in how ARRS staff are allocated across different PCNs. So we weren't prescriptive to the PCNs in terms of how they would go about treating patients to target. And it was very much, PCNs had to be flexible and look at how their ARS staff were distributed to know exactly how to carry out the project within their region. And then also during the process of the project, the QOF targets was changed. So if we were previously treating patients to a non-HDL cholesterol of 2.5 or less, or an LDL cholesterol of 1.8 or less, but then that was changed following the publishing of the NICE guidelines, and that was changed to 2.6 or less for non-HDL cholesterol, or 2 or less for LDL cholesterol. And so that meant that sort of MEAD program, we needed to rework the data. We needed to rework the service spec for the PCNs that were carrying out the targeted incentive scheme, because we didn't want a situation where they were doing work that was sort of in contrast to what surrounding practices were doing, and then as a result have them disengage from the project. And I've also talked about the GP collective action. Another big challenge for us was around primary care access to inclisiran injections, and I'm sure this wouldn't at all be a surprise to anybody. Most regions have had this situation, especially with the RCGP and BMA position and LMCs around the country not supporting the use of inclisiran injections amongst their primary care clinicians. So that also was a huge challenge for us. But it also actually makes some of the results that we saw even more sweet and more inspiring, because despite those challenges, we were still able to achieve lower cholesterol levels for our patients, and that was definitely something that was great for us to see. So just looking at, so this was the percentage of patients not treated to target prior to starting the project. As we said, the patients in our core 20, so that's the bottom bar line, they were the ones most likely to not be treated to target. But as a result of this program, what we saw was a massive reduction, not just in our core 20, but also in the decile 3 and 4 as well. Now, it might look like all of a sudden the patients in the higher deciles were less likely to be treated to target, but actually just because it was percentages, it looks like, yes, their percentages increased, but actually what we saw was across the entire group of deciles, there were reductions in the numbers of patients that were not treated to target. So even though the work was targeting patients in the core 20, particularly in the PCNs where there was this targeted incentive scheme, that benefit was seen across the entire group of patients. So even patients that who were of a different decile population, but more of them were treated to target compared to what we were doing prior to the project started. So I have said a lot, and I know that it might be a lot to take in. So, I think it'd be good to sort of start to look, if anyone's got any questions, please ask them, and we can, if there's anything that's unclear, we're happy to expand on it a little bit more. But that's our project. And yeah, thank you very much for your time and for listening to us.
Thank you both so much. That was so interesting, and I think kind of looking at that final slide with figures on says a lot. Move us on to Q&A. I've got a list of questions that I'd love to ask, but I'm conscious that we've got others on the call as well. So everyone, please feel free to use the chat for that. But just to begin, you spoke about kind of the targeted funding that you had within kind of hospitals and Doncaster Royal Infirmary, which was on there. Which was kind of there to kind of support the building of capacity and kind of reduce waiting list times. I know that can be tricky, and we all know workforce can be really tricky and capacity is really challenging at times. How was it kind of building that capacity? What was it that you did, and what was the process behind that to make sure it was successful?
So just for clarification, are you asking about the secondary care capacity then?
Yes.
Yes.
That's it.
So with regards to our secondary care capacity, we did some work with so the place where they had the longest waiting time, we did some preliminary work with them to try and work out so how many clinics they were currently putting together, how many were for first time patients, how many were for follow-up appointments. And then at the time we'd also been working with them to sort of come up with a proper pathway for referrals. Part of the reason why they had such an inflated waiting list was as a result of the IIF work that had happened just a couple of years beforehand. And so they'd had a lot of referrals to a lot of referrals to the lipid clinic around that sort of case finding for FH. So we had been working with them already to create a proper pathway for referral for FH, but then also just to work out what the referral pathways were for the different classes of patients. So whether that was FH, whether that was just secondary prevention patients needing PCSK9 inhibitors. So that sort of articulating that pathway was part of this work, and educating, and we worked with place clinical leads, so GP clinical leads at the place to sort of help us with this, to help us to articulate and to share what the appropriate referral pathways were as part of this work. And then based on the work that we'd done with the secondary care clinic, we were then able to fund a finite number of additional clinics for first appointments so that we could then drive down that waiting list. And I think we did it, how many months was it over, Daniel? I can't remember.
Yeah, I can't remember the number of months exactly, but I think that's it. I think there was a kind of foundation of having the right pathway and therapeutic options in place. We worked with the clinic to look at what that additional capacity could be put in for the funding available, and then working with some of our place clinical leads to look at the ensuring that all referrals to the clinic were appropriate. And produced a top tips document alongside that to make sure that all the right pathway had been followed, the right information had been shared. So we were trying to have the foundation of the pathway in place, increase the capacity whilst reducing demand, but making it a more reflection of appropriate demand, I think, is probably a better way, so that we were reducing that waiting list as a totality. So that was the approach for that bit of work.
I think evidently that's a really good approach, and I think looking at that 6,000 plus, the figure you put up before, it's evident that actually a big part of, I guess, pathway management is that kind of project management side, isn't it? And making sure that you've got the right people in the room to almost support that change, because as we know in the NHS, it is tricky capacity, and actually sometimes it just takes having people, who can see the vision of what that future looks like. So yeah, some absolutely brilliant work there. I guess moving on from secondary care to kind of your work that you've done in primary care, I guess similar to kind of capacity and resource, we know that sometimes it can be quite difficult to engage within primary care and PCNs, and you managed to get 18 on board, which I think is a brilliant number. How was it engaging with them? I know you mentioned that there was, of course, different parameters in kind of incentivization. What was the process of obviously engaging them to begin with so that they would then support?
Yeah, I'd say I think it was really positive interactions that we had with the leads. I think people see the value of the work taking place, and I think what people appreciated was the fact that we took that kind of that health inequalities approach to have the greater targeting of funding. So we looked at what the different funding options would be. So if we worked with every primary care network, what would be the price per patient treated target, or what if we just worked with a finite number. So I think there was a wide bit of engagement within the ICB about what's the appropriate model for that. But I think what the real strengths of this project were is how we created a framework for change and then allowed that kind of local adaptation. So some of the pushback we got later on in the process was a bit of a misunderstanding about a perceived promotion of a particular therapy or drug, and actually we could go back and say, actually no, we're just focusing. This work is purely focusing on outcomes. It's purely focusing on the number of people treated as a target within our most deprived populations, and actually how you go about that is up to you. I think it was great that we used a primary care network wide approach, so that actually there was kind of that ability to share resource and work differently across a primary care network, but also kind of have that higher level of funding available for a particular PCN, which was fantastic. And yeah, just to kind of allowing supporting the PCNs to take a approach that would be delivered best within their PCN. And I think that was really exciting to see how the majority pharmacists within the teams took on that bit of work, and were really proactive with that case finding. We did see the greatest impact, as Evan said before, about where those PCNs really took it under a particular person's kind of remit and brought about that change. So I think it was about creating that flexibility to allow that local adaptation, and people were really keen to be on board with it. So the engagement was great. I think that challenge mid-year around actually kind of having to have a bit of a reset for the targets was a challenge, but I think everyone was on board with that and responses to it, and it's something that we'll look to do again in the future. Evan, was there anything that you missed? Yeah.
No, I was just going to say as well, part of the approach as well was we actually provided pump prime payment to the PCNs, so a 20% pump prime payment to the PCNs, to allow them to make all the any necessary investment in workforce, in resource, to be able to carry out the work, which I think was also something that is not usual with local incentive schemes. You sort of get your payment at the end, and there's a lot of upfront cost and investment and risk that the practice or the PCN has obviously got to take on themselves. So I think that definitely also helped with the engagement out the gate, the fact that we were able to provide that. So
thank you both. And I think I agree, Ebun. I guess pump prime funding is always helpful, isn't it? And you're right, you don't often see them in this area of work. So I think that probably definitely was a really good incentive for people to kind of onboard themselves. But I think as well as that, I guess touching upon what you were speaking about, Daniel, it feels like there was a lot of co-design within the process. You created that kind of theory of change and that framework, but actually you allowed each individual organisation to tailor it to what they needed. And I think that goes far when people, I guess, get to input and get to embed their own thoughts into how that change should look. And I think co-design definitely goes far, and it helps with that people investment side, doesn't it? When people feel invested because they are fully engaged and involved, that can make a massive difference. I guess speaking about involvement then, so you mentioned there was the 18 PCNs that were involved within the South Yorkshire region. What happened to those that weren't selected? Are they still looking at health inequalities? I'm conscious that obviously health inequalities and Core 20+5, etc., is such a massive health agenda, and there are parts of that within the NHS new 10-year plan as well. What happened to those who weren't selected?
So as you said earlier, we had 4 strands, didn't we? So even though there were other PCNs that weren't selected for the targeted incentive scheme, there were, the other PCN, every PCN within our South Yorkshire region was able to benefit from the education, was able to benefit from, some of the stuff that we did around patient education and awareness. And obviously the work that we did with the local lipid clinics also meant that they were able to benefit from that as well. I think for, particularly in terms of being able to access the education, I think it was a testament. That 6,000 is basically across the whole of South Yorkshire. And what we found was even the PCNs that weren't involved in the targeted incentive scheme, there was already QOF. So there was a scheme already in place that actually rewarded treating more patients to target, and actually the education that we provided was supporting those practices to, in terms of meeting their QOF targets as well. So even though they weren't selected for the targeted incentive scheme, all in all, it felt like everybody was a winner, I think.
It sounds like with this project, it wasn't a instead of QOF, it was here is an add-on that can support, which I think is always helpful when you kind of frame a project.
And I think it's the reason, sorry, I was just going to say, I think, it's part of the reason why, QOF obviously does need that review, because it's very punitive for practices where, whether as a result of capacity, whether as a result of competence, they're not quite meeting that minimum level that's required in QOF. And as I said, especially for this particular indicator, we had quite a few of those within our patch. And so, sorry, excuse me. So those practices, actually, it's very disengaging, because it's a lot of work just to be able to meet the minimum threshold. And the minimum threshold is just, you don't start to get any remuneration or any incentive until you've exceeded that minimum threshold. So, it was very important that at the very least, this actually helped to level the playing field for all of the PCNs in terms of their ability to be able to engage with this indicator.
Thank you, Ebun. I think it's evident, isn't it, that actually there are parts of this project where funding was really important. And I think it's that co-creation plus funding which really helps this move forward. I guess final question, linking in with funding. If there are, let's say, commissioners in this room or colleagues who are really keen to kind of look into health inequalities and look at kind of work within CVD, what would you say is the main reason why they should look at funding areas of this work?
I think
Tough question.
I think yeah, I mean, I think it comes back to those kind of first slides that I presented, just around the real impact that circulatory diseases can have on people dying earlier than they need to, earlier than they should in South Yorkshire. So I think, and it comes back to the fact that, yeah, it is preventable through managing those conditions, having healthy lifestyles. And I think the other way that I try to look at it as well is the fact that we're talking about cholesterol for a particular indicator, but I think it's a means to get a person in front of a clinician that they may not have ordinarily have done. So actually, a holistic conversation will happen, once that person's in front of a clinician. So actually, the aim is to work through a particular indicator to then bring about holistic care, as a result of that. So I think there's a huge amount of opportunity for people, dying early, and there's a huge opportunity for interaction on other conditions as well that need to be worked through. I think the other challenge that we often get is, well, there's pockets of health inequalities in all PCNs, and I would say there are, but it's more in some areas than others. And I think we're really fortunate that we've got some health inequalities data through CVD Prevent and the great work of the Northeast analytics team, Northeast Yorkshire analytics team, that actually shows that people who are living in more deprived areas are less likely to be treated as target. And I think that's just a real kind of stark call to action for us, of actually we need to do more to support these people and to create frameworks and incentives to support these people.
Thanks, Daniel. Ebun, any final thoughts from you? Conscious of time.
No, I think anyone who wants to sort of embark on this type of work, it's definitely worthwhile. The results say everything. As an ICB, it's always been our ethos to reduce health inequalities, and actually, to be able to show tangibly that we've done it, we are doing it, is, it's definitely inspiring, at least for me anyway. Even though I was a part of the work, it's still for me the reason why I get up in the morning and I do the work. So it's definitely worthwhile to do. And as you can see, from the different strands, there are so many different ways that you can come at this, and all of them important, all of them necessary to be able to achieve the results that we're talking about. So I think it's also important to sort of highlight the PCNs that actually engaged the most with this and actually achieved the biggest results with this programs were ones that took a program management approach and actually used not just the clinicians, but also actually non-clinical staff within the PCN to do this work. So, it's not just about the clinical staff and the clinical capacity, but actually how can you also use your non-clinical staff to get some of these things done, sorting out appointments, creating the patient lists, contacting patients, booking them in, arranging follow-up. All of those things are aspects of the work that actually having a well-oiled machine, a program management approach actually means that you're more likely to have success with it.
Thank you, Ebun. I absolutely agree. It is about, like I said before, it's that holistic view, isn't it? Making sure that everyone is involved, because transformation is lots of people getting involved to support for that change. Thanks for attending, everyone. A massive thank you again to both Ebun and Daniel for joining us today. As I mentioned before, all of our bite-sized series will be recorded and uploaded onto our website, which is just in the chat. As I mentioned earlier as well, this is a part of a whole bite-sized series. So to book onto future sessions, again, you can head to our website and you can book those on. Thank you. Goodbye.